All right, guys, it's time. Welcome to Greater Than. It's one of our Masterminds events. We haven't done one in a really long time. If you guys haven't met me before, my name is Austin Ellis. I'm one of the trainers here. One of the things that Greater Than kind of prides itself on is we do a fair bit of work with people with pain and injury. It's rehab setting, but it doesn't look quite like when you go to the physical therapist's office and it's doctor-ordered stuff and we only work with like a band or whatever. So we do some post-surgical, but it's kind of like that in-between step. Like maybe you haven't quite made it to returning to the activities you'd like to, but you know you're not like clinically broken anymore. So, but you need some more help. That's why I really wanted to bring Katie here today because she's one of the few people over the last couple of years I've had the privilege to call coach, and I think she's really bright. She has a good message. She has this whole thing that this is a mini version of it. Training is healthcare, right? She travels all over the world to talk about, and I think it's really all over the world. The only country that matters. But I think there's a shift kind of happening right now in the fitness, wellness, rehab world. Where there's a lot of kind of maybe even like old wise tales about what you can and can't do with the body, what you should and what you shouldn't do, and you know, moving like that is dangerous, and moving like that is ideal, and you know, the old systems of RICE for your rest, ice, compression, elevation for your acute injury type stuff. But we've kind of noticed that isn't really cutting it anymore. It maybe never really cut it completely, but for let's say the average medical doctor, it's much easier. It's not their wheelhouse to teach you how to overcome tendonitis in your sport, to rehab you back to a level to where you can play pickup basketball without your knees hurting. They might see you for 10 minutes, right? And so I think we're in a really good position as fitness, wellness trainers, physical therapists, chiropractors, to kind of span the gap there and help people find out that there are tons of ways you can move. There's no necessarily ideal way for anybody to move. You don't have to be afraid that your spine is fragile and it can never recover from being hurt. But a lot of people haven't heard this information yet. For us that do this every day, it might kind of seem really old, like, oh, that's old info, duh. But to the average person, they still go on Google and they're like, my knee hurts, what should I do? And they go see their doctor and they say, hey, stay off of it. And that's really just not the ideal plan, right? We know that normally most of our aches and pains and acute injury stuff outside of like just tragic accidents like car accidents, getting shot, something like that, is gonna come from doing activities where you have exceeded the capacity of whatever tissue that got angry at you doing whatever event. And so if you said, you know, I can only do 100, and then you competed and you did 110 at whatever speed or measurement we're talking about right now, and that's what hurts you. And then you take 6 weeks, oh, just let it calm down. Yeah, it's tendonitis. If you just leave it alone, it'll get better. And they're not wrong. The natural history of injury will tell you that eventually this will mostly right itself, but it will not be able to compete and give the kind of output you're looking for that it once did prior to that injury. You stepped over the line, you crossed its capacity. You rested for 6 weeks. What happens if you're in a cast for 6 weeks? Anybody ever been in a cast? A lot of atrophy, right? You're gonna have stiffness, you're gonna have muscle loss, you're gonna have bone density loss, and there's interesting things that happen to your tendons when they're immobilized for a long time. So really, the goal wouldn't be to take a whole lot of time off, get yourself weaker, you feel a little better, then you return to your activities and the pains usually will come back if you did not prepare those tissues for the next step. And so, really we're trying to make more of a shift where it's preventative and not waiting until there's some kind of disease process to start treating somebody. And then teaching them that just because you have some pain or a limitation does not mean rest is the only option. There's tons of things you can do and stay moving and build your capacity and your confidence. And the other part that I think she's probably going to touch on today is the biopsychosocial model of pain and injury with athletes or just people in general. Because for the longest time, medical world had a pretty physiological only based view of how pain would work. So I might be able to take an MRI or an X-ray to a few of you in here that maybe have a back that aches every once in a while, or I hurt my knee in high school playing football, but it's pretty normal now. A doctor might be able to see those X-rays and say, that's a knee that requires surgery. That's a back that requires surgery. The person might not have a single issue. And so there's obviously, it's not a one-for-one kind of thing. We can't just say, the damage is there physiologically, then you must hurt, and you must be fixed this way, right? So there's lots of other things that come into play when we're talking about humans. They're pretty complex systems. It's not as simple as saying, oh, you know, your back looks like that, you should not be able to deadlift. I don't know, I always forget his name when I need to think of him. He was the first guy ever to deadlift 5 times his body weight. And he has scoliosis that you can see from across the street. And it actually, I think, helped him, because it made his torso really short, which helps you. But,
so he was cheating.
Yeah, that's what I'm saying. So, but that physiological only viewpoint of how your body works and how pain and injury works would tell someone like that, you probably shouldn't bend your back ever and never lift anything over 10 or 15 pounds, right? And yet, you're one of the strongest dudes that ever lived. And so I really want to just see a mind and a shift in the mindset of our world to where we can really address these folks as individuals and people and help them find ways to move like for a lifetime and not just worry about, you know, I can't bend my back ever again because the doctor said more than 5 pounds and my vertebrae might explode or something like that. Anyway, that's all I was going to say. It's just kind of a preface for all this. This is Dr. Katie Dabrowski. She's a physical therapist who lives out in Florida, and she has 2, right? Almost three gyms called Old Bull Athletics, where they do a whole lot of stuff like this. And I learned a lot from her when I studied underneath her. And I'm excited to host you here. And you guys, I hope you learned something from her as well. Thanks for listening to me.
Thank you. Hi guys, I'm excited to be here. Thank you so much for having me. I came in from Miami this morning, so honestly, just being in a slightly less humid climate already feels better. This feels like fall to me, which is sad. It means a lot to be here because I've always really enjoyed looking at what you guys do. Your facility is something that I think is pretty rare, unfortunately, in the fitness world. Collaborating between different practitioners, having a space that's really movement and strength based, which is awesome, and just that like collaborative effort that I think is so important. And then on top of that, having the pleasure to get to work with Austin, it just means a lot to be here. So thank you. So today is all about training as healthcare, as Austin was prefacing, and really gave basically a perfect summary of what today's talk is going to be about. Kind of blurring the lines between training and rehab. I don't really think they're too different. I think they're actually quite similar, and just some minor things that might be different between the two. And then also that realization of like a rehab provider is not the only person who's going to see somebody in pain. Actually, trainers and coaches are probably going to see somebody in pain way before they'll ever actually undergo rehab. So how do we make sure, regardless of what our licensure is, degree is, letters after our name, how much crippling student loan debt you have, how do we make sure that we are all well-versed and able to handle pain when it's appropriate within our scopes of practice, and kind of regardless of diagnosis. That's a big thing that I harp on a lot. I don't really care about a diagnosis. Unless there is a component of it that is dangerous for me not to consider, I really don't care. And I'm not saying that to just be like flippant and rude about it. It's more, it doesn't matter because we have to just make the person's knee a better knee and their body a better body. Not necessarily get really into the weeds about what the specific structure is. Again, unless there is something that warrants the need for that. That also evens the playing field, I think, a lot for rehab providers and coaches. If we start to realize that we do a lot more of the same thing, we can learn a lot more from each other. As a physical therapist, I would say one of the most embarrassing things about my profession is that we are so not well versed in program design, strength and conditioning principles, energy systems, all the stuff that trainers and coaches have expertise in. And it's something that I think from across like both professions, and I say physical therapist because that's me, but I mean all rehab providers, we need to do a lot more to learn from each other. So that's a big goal of this. A little bit about me. I wear a few different hats. I started as a neuroscience researcher, and I finally realized that I wanted to spend time with humans and not rats. So I transitioned into the clinical setting as a physical therapist and strength coach. My background is rowing, and now I'm whatever we call a hybrid athlete. I'm just like mediocre in a lot of different things, so I can train across the full spectrum. And I'm co-owner of Old Bull Athletics, as Austin was talking about. We are very similar to you guys. Like walking into a space like this makes me feel at home. A lot of heavy weights, turf, not a lot of passive stuff going on. And we blend rehab and training. All of our providers are also strength and conditioning specialists or have some sort of strength and conditioning or USA weightlifting or powerlifting certification to be able to span that full spectrum of care. I'm also a neuroscience faculty member at Nova Southeastern, where I was actually an undergraduate student, so I get to be kind of wear those hats of really staying involved in academia and then also getting to treat patients. And then I'm the director of Gifted Academics, which is a certification prep resource for anybody who might be interested in getting their CSCS or getting their CISSN through the ISSN, Certified Sports Nutritionist certification. Just trying to help level up everybody in the profession with these certification offerings. And then I'm an advisory board member for Society of Sports Neuroscience. If you guys are interested in that intersection of neuroscience and exercise science from an applied and academic standpoint, this is a really cool organization. So if you have questions about it, let me know. And then my biggest passions are blurring the lines of training and rehab, understanding the physiology of pain, and then also not taking ourselves too seriously in this industry. I think Instagram has become this really weird rabbit hole of people hyper fixating on things as trainers and coaches, and as rehab providers, probably even more so. And I think at the end of the day, we just need to remember we have such a cool job. When what other profession do you get to interact with people who come from every walk of life and every profession, every background, who are electing out of their busy lives to spend an hour with you? It's pretty cool. So those are some things about me. I want to learn a little bit about you guys. So raise your hand if you are a rehab provider. Cool. Raise your hand if you are a coach, trainer, any of that stuff. Cool. Raise your hand if you are a client here. Awesome, very cool, love that. Raise your hand if you yourself like to lift, run, jump, do all of the things. I was hoping that everybody would say that. Raise your hand and say what you are if I didn't cover it. I think we're good, okay, cool. This has a little bit of something for everybody. This is something that I want you to consider from a client-facing standpoint, but also for ourselves. I think it's really easy for ourselves to get wrapped up in a lot of this stuff having to do with pain and injury when it happens to us too. I had radial nerve entrapment this past week because I decided to do like a mountain race that I'd never done before, and I'm basically just like dipping myself down the whole way for 6 hours. And I woke up with my arm numb, and I went through this like catastrophizing cycle of thinking like, all right, here we go, I can't use my arm anymore, I'm doomed, my training's gonna suffer, all of this stuff. The things that I tell my clients not to do, I was doing it in real time. I looked at my fiance and I said, do you see atrophy? Like immediately, within a day, and he was like, please relax. So just a reminder that we all do this ourselves too. So I think this is something I want you to also take personally into our own practices of how, you know, we are bodies that want to move and stay active, but of course we're gonna encounter stuff. So just some reminders there. My arm's fully functioning now too, so you guys are good luck because it's feeling a lot better. A little bit about today. Together we're gonna talk about reimagining healthcare, understanding the physiology of pain and stress. We're gonna develop an actionable framework for dealing with people in pain. We're gonna identify general principles for managing pain regardless of diagnosis. We're going to utilize our client history taking as a roadmap for finding patterns. I love finding patterns to simplify my thought process for what I want to do with somebody, so we're going to work on that a little bit today. And then elevate our roles as a very important part of the healthcare team. Obviously the title of this course, Training is Healthcare, I think you know what my thoughts are on that. I'm a firm believer that trainers and coaches are at the front lines of healthcare. You're not going to find another provider who sees their clients or patients more frequently than a coach, a trainer, or a rehab provider in this type of setting. It's an exponential difference for how many more touch points we have on somebody than their primary care provider or any other medical provider they may see. And none of this is to knock that. I'm not about knocking other practitioners. This is more to just make us realize like, oh, what we do is actually pretty important. And we have a lot of opportunities to impact and make a change. And I know, I'm sure we can all run into this, like sometimes you have that client where they're talking more in the session about what's going on in their life than maybe you're getting like enough of a stimulus as you would like to give them. And sometimes that drags me down and I'm like, God, am I really helping this person? Am I giving them what they need? But I think if we flip that to realize we're giving them exactly what they need. We're giving them exposure to movement, we're giving them a sounding board, and probably also, again, the only time in their week that they're actually spending on themselves. So a little bit of a mindset shift here, as we were talking about earlier. So first with reimagining healthcare. This is something that is part of our mission statement at Hopeful, and I think it probably aligns perfectly with exactly what you guys do here. The future of healthcare is movement-based, creates resiliency, and proactively prepares people for the challenges of life. Unfortunately, that doesn't seem to be the case when we look at healthcare as a whole, but I think it's something that finding more and more of these places around the country, around the world, if we can live by this type of motto, if we can really live and breathe it, I think that makes a huge difference. And movement is our scope of practice. I say this all of the time. I don't care what credentials you have, what licensure you have, what letters are after your name. Movement is all of our collective scopes of practice. And the gatekeeping that I think exists between industries sucks. Or even between rehab providers. Like there's wars against chiropractors and physical therapists and athletic trainers, and it's so silly when I think we need to just realize that this is the truth at the end of the day. And we're all healthcare providers. That's a huge component of today's talk. So this is the average number of physician visits per person by country. We'll zoom in on the US. Less than 3 visits per year in the United States. This is the 2019 census, and that's a great average for you to keep in your mind. About less than 3 times per year people are seeing a physician. We all know there's plenty of people who never see them. And let's compare that to how many times we'll see our clients each year. If you assume you see your client 45 weeks out of the year, considering like holidays, vacations, sleeping in and missing their session, all of that stuff. If you see them twice a week, that's 90 visits. 3 times per week, it's 135. 4 times per week, 180 visits. That's a huge difference compared to less than 3 times per year for a physician. And we're coming from a world where, however, the physician tends to be at the hierarchy of medical care and kind of the gatekeeper to medical care. Yet, who's getting exponentially more touch points with their clients? Trainers, coaches, rehab providers. So that also, think of too, like, how maybe sometimes too comfortable our clients get and they're telling us all their life story. But that's because they see us so frequently. And for some people, some of my clients I see more frequently than any of my friends in a week. And remembering that, it's because they trust us, it's because they're confiding in us, and because we have, to them, we're positioned as a person of authority in healthcare. And I think that's important for us to remember. And again, none of this is knocking physicians, I promise you. These are just some examples. There's a few studies that show really interesting information, just how little physicians are prepared for huge movers in people's health. Physicians don't know about exercise prescription, strength training, and physical activity guidelines. A 2021 study of almost 500 American MDs, these are some interesting findings. About 27% said they felt they could prescribe an appropriate fitness plan, yet most people, when somebody comes in and has maybe unfavorable blood labs and anything going on, what do they say? Diet and exercise. They don't know how to actually prescribe that or what that means. About 60% could accurately report the aerobic recommendations for physical activity guidelines, and only about 43% could accurately report that there was even strength training guidelines as well. And this is about 400 MDs in Canada. 95% reported prescribing exercise to their patients would be beneficial, but about 15% reported that they were adequately trained in exercise prescription. So they all know it's important, but they're not trained to do this stuff. That's what we're trained to do. And a ton of MDs in Brazil, 95% reported needing more information on physical activity guidelines, and 75% of them reported just flat out incorrect physical activity guidelines. So, I think again, this positions us as truly experts in this area. Like, this is our bread and butter, this is what we get to do every day, and it's important for us to remember that. That brings us to another topic of the necessity for surgery in common musculoskeletal cases. Again, there are absolutely instances when people need surgery. We all know that too. This is an interesting deep dive into a lot of huge meta-analyses and systematic reviews, which basically just take a ton of evidence and combine it all together to give us a big clinical picture of just how frequently surgery is used with little to no change in somebody's pain, function, and quality of life. The reason they went and got surgery in the first place. Or, unfortunately, in some cases, decreased measures of all those things that I just mentioned. So this is a study, and I'll have links for all of these studies that I'll be able to send to you guys too, so no worries, you'll get all this. 6,000 randomized controlled trials, so all of those studies where they're just looking at, comparing a few different groups. This is a systematic review or meta-analysis that takes all of those together, so 6,000 of them. First and foremost, many of the studies did not use control or placebo groups at all anyway. And meaning basically they did not compare to people who didn't get surgery, and then they just said surgery worked, which, about science, it doesn't really work that way. Those that actually did use control groups, their whole question of evidence, all of their finding in those studies showed no differences in surgery versus non-surgery measures of pain. Most people are getting surgery because they're in pain, or they need to improve their function, and we're seeing a considerable proportion of people who have no changes whatsoever. This is great because it breaks down things for the most common musculoskeletal surgeries performed. And these are for non-traumatic injuries. Again, it's kind of what you mentioned, you don't see a ton of post-op here, same with our clinic. It's a lot more of just like general aches and pains. People who wouldn't necessarily qualify at like traumatic injury standpoint, of course we still see it, but this is looking at non-traumatic pain, just like everybody's normal day-to-day pain. The big clinical question is, do common musculoskeletal surgical procedures produce better pain relief than no surgery? They looked at over 100 studies as well, and the following studies showed no differences between pain between surgery and not. So 3 out of 4 studies of rotator cuff repair, 14 out of 15 studies of subacromial decompression, 6 out of 8 studies of carpal tunnel decompression, all studies of spinal fusion, all of laminectomy, and all of meniscectomy. That's wild. That's absolutely crazy. So this starts to paint that picture again. It's so much less about a structure that needs to just go in and get fixed. It's a lot more about a body that needs to be better prepared to tolerate the demands that you're placing upon it. And just another example here, this has over 100 studies with 12,000 patients across 28 different conditions. 13 of those conditions had data on pain. 9 out of 13 of those studies showed no differences in pain. 11 conditions had data on function, what were they actually able to do. 11 out of 11 showed no differences in function. 9 conditions had data on quality of life, and again, none of those showed differences in quality of life. Kind of beating a dead horse here, but I think it's important to see these numbers because it's pretty prolific. And then this, I love including this too. This is a more recent report. This is an observational retrospective study, so they're just making an observation looking back in time at some information of the association of the initial healthcare provider for new onset of low back pain with early long-term opioid use. The findings are pretty interesting. People who saw a physical therapist or a chiropractor first had markedly decreased likelihood of ever using opioids. People who had low back pain and saw their primary care provider first had significantly higher likelihood of now going down the spiral of getting addicted to long-term opioid drugs. So again, like who you see first matters. Everybody who can come and see you guys first, that's insane for somebody's quality of life and a really scary potential outcome of long-term opioid use. This again speaks to that huge level of importance of understanding how multifactorial pain is and not going to potentially a physician who's very, very well trained in the biomedical model of if this, then this. If this body part hurts, then this structure must be something wrong with it, or it must need to be fixed, or it's something as simple as the structure is bad. How are we doing? Fired up, it gets me excited. Too excited. Okay. So I like having actionable things for people to take home. Again, for ourselves, for our clients, for anybody that we would encounter. So we're going to look at a few of the things that I utilize as my general principles for when I'm managing pain and when I'm working with my team. Again, regardless of scope of practice, how to manage pain. We'll zoom in a little bit more and look at how taking a client history provides so much information to be able to direct us for what we need to do. Beyond a lot of like the poking and prodding and testing that I think a lot of us think that we need to do all of the time, there's a lot more just what somebody's story is. that can really guide us. This is one of my favorite quotes. As to methods, there may be a million and then some, but principles are few. The man who grasps principles can successfully select his own methods. The man who tries methods ignoring principles is sure to have trouble. I love this quote so much because it really harps on the idea of there isn't a formula, there isn't a recipe, there isn't a perfect method, there isn't a, oh, you have this diagnosis, therefore this protocol needs to be put in place. This is all principles based. If you understand the principles, you can tackle anything. They're applicable to everybody. They can be titrated up and down. They can be adjusted as needed. And they're appropriate for any person you would ever encounter and ourselves. So these are my general principles for successfully managing pain and injury, regardless of scope of practice. One is understanding the complexities of pain. I don't think we have to have a pain neuroscience lecture with our clients, but I do think us as providers, it's really important to understand some of this stuff. And to appropriately talk about it with clients when necessary in a way that's digestible. And again, as much as I love neuroscience, I don't think any of my clients want to sit and listen to me give them a lecture about it. Meeting physical activity guidelines, finding an entry point, progressive overload and load management, and non-diagnosis driven care. This is stuff that I implement, my team implements, and it's all principles based. There's nothing magic. There's nothing, this is the one movement you must do to fix your back pain. This is all about being very principles based to be able to address anything that you would need to. So understanding the complexities of pain. I think we could go down a rabbit hole here and get super in the weeds of pain science and pain education. And I think really sometimes even do our clients a disservice of over-explaining things. Or the opposite of what we ever want is making them think that we're telling them their pain is only in their head. Like that's a terrible thing to make somebody feel. Even though there is a neurological and cognitive component of pain, absolutely. We want to tread very carefully to never make somebody feel that we're telling them their pain's not real. So this is something, and we've all probably gone overboard with explaining that. Like I know I used to probably explain this way too in depth because I love it and I think it's super important. But to a client, they might only need about this much of it. But I think it's important for us to be aware. So what is pain anyway? There's a few quotes that I love to explain pain. All of these people here that are mentioned are pain researchers. Again, we can give you links to any of them that you're interested in. Pain is an unpleasant sensory experience associated with actual or potential tissue damage with sensory, emotional, cognitive, and social components. And I bolded actual or potential on purpose because again, this centers upon even just the fear of pain or the remembering of a past experience when you've had pain with a certain movement can create a very similar neurological, cognitive, social, physiological response in the anticipation of pain. It's really important. It's not only because something actually happened, there could be a potential threat that somebody who is very flared up and they are so aware of every sensation in their body. This is something that's huge and happens all of the time. We've all been there. Like I said, I had an issue with my arm, and like the day it happened, I thought I had atrophy already. And of course I did not. But my brain immediately went to that because I was starting to spiral and think of all of the things that would be impacted if my arm continued to be this way. And that's huge. This happens all of the time. J.P. Pinheiro is an excellent pain researcher out of Brazil, I believe. So definitely worth checking out if this is an area that's interesting to you. The meaning assigned to pain drives cognitive, emotional, and behavioral responses. When pain is threatening and a person lacks control over their pain experience, it can become distressing, self-perpetuating, and disabling. I think the control portion of this is really important. How many of you have been in pain before? Perfect, all of us, I would expect that. How many of you would agree that not knowing what the hell your triggers are, or what sets it off, what calms it down, feels terrible and makes you feel out of control? That's one of the worst parts of pain. Not knowing what you are doing to make it better or worse, and feeling like your body has a mind of its own, and it's doing whatever it wants, and you never really can expect day to day what it's going to feel like. And we all have the luxury of actually having a background in this stuff. So now imagine the people who do not have a background in this, and how disabling and crippling this is mentally to deal with. We are people, luckily, even though again we still freak out ourselves, who understand that not all pain equals harm. We understand that there's a lot at play here, but it still becomes disabling for us. So I think it's really important to remember the luxury that we have of understanding the human body better than the average person does, but that it still freaks us out when it hurts. So imagine how much harder it is for people in their day-to-day life who, is an accountant and has no exposure to anatomy and physiology, how scary everything they feel is. People truly think that if their knee hurts, they've torn their ACL, or they have something going on, something is wrong in my knee. And it's really scary for people, and I think remembering that keeps us a little bit more grounded in when we're dealing with people in pain too. And I don't know where I found this one, probably like on the internet somewhere. All injury is brain injury. And I say this because I think it's important to remember that at the end of the day, pain, injury, all those experiences do leave a lasting impression in our brains. Our brain's job is like to keep us alive. It's pretty good at that. So we're gonna remember stuff that hurts. That's on purpose, that's a great adaptation. But when it becomes something that is so at the forefront of our awareness all of the time, it's a little less helpful and it's a little bit more maladaptive. So you have to remember too that yes, the brain remembers all of this stuff, but the brain is super plastic, and we can also give a ton of really good experiences with movement to help slowly over time, like drown out that noise of how scared it was in the first place. How are we doing? Does anyone need like a bathroom break, water break, anything like that? I like to sprinkle in breaks because I don't think anybody wants to sit and listen to me talk for an extended period of time. Or questions, yes?
I was going to ask if we could ask questions.
Of course, yes.
Question.
Yes.
So with the whole doctor thing, do you have strategic doctors that you partnered with that have the same mindset you guys do? Or is it random? Or
It's hard to find people who align. The good thing is I would find with like this newer generation of physicians, you're getting a little bit better. But yes, we do have a group of physicians that we trust and work with a lot at Old Bull. And honestly, a lot of them are DOs who are a lot more kind of human-centered, I would say. And again, none of this is to knock MDs. Just the training, I think, aligns a little bit more with a lot of what we do as rehab providers and as coaches. And then also, my favorite type of physician is a physiatrist. They're basically like the MD version of what a rehab provider is, and they are phenomenal. So there's actually, when I had the arm injury going on, there's a doc that I had like a texting relationship with because we're always sending people back and forth, and I was like, I'm tagging in myself in this one, can you help me please? But physiatrists are incredible people to connect with because they tend to be very conservative based, and they tend to be very aligned with what we do as coaches and rehab providers. This doctor in particular, he actually has like a gym set up in his office because he knows that that's part of treatment. It's so cool. Like I've never met anybody like that before. He actually sought us out. He found us online and came in to talk to me. So I would say find some physiatrists, find some DOs who are in the orthopedic world that really align with what we do. That's been huge for us. Yes.
follow-up question? Pardon my ignorance. What's a physiatrist?
Yeah.
I've actually not heard of that.
Yeah, physiatry or physical medicine and rehabilitation, PMR docs, they're pretty synonymous. It's kind of like an orthopedist, but they specialize more in conservative management. So they're not a surgeon, they're not necessarily going to refer to surgery. They also like more conservative management, utilizing like diagnostic ultrasound instead of jumping to MRI or jumping to X-ray, which I think is really important too. They do like nerve conduction studies, things like that. Yeah, there's a lot of overlap between what an orthopedist and a physiatrist would do. In my experience, I just found that a PMR doctor or a physiatrist is much more aligned with what we do.
Amaranth's client Brenda is a PMR doc.
Brenda.
Oh, really?
Thank you.
Is PMR, is that the abbreviation you would see in the
Yeah,
so like
it's
MD?
physical medicine and rehabilitation, PMR. It's not, it wouldn't be like after your name, it would just be like the title of that.
Okay.
Yeah, yeah.
Keep that in mind.
But definitely worth exploring. And then also, to be quite frank, like finding a physician that's a concierge physician rather than in a big hospital group, it's probably gonna be a little bit better too. Especially if they have patients who value one-on-one care or who value that more, client, patient, provider relationship. That would be my recommendation too. Are you good on a break, or are we good here? Anybody?
We're good.
Anybody there? Alright, so these are the proposed models of pain. They kind of go in order from where we started to where we are now. And I could do like an entire semester on this, so we're going to do little baby bites of each. If you have more questions, let me know. But the biomedical model, mature organism model, allostatic loading model, and predictive processing or Bayesian model. We'll start with the biomedical model. This is super linear. This is what Austin was talking about, like being just very only physiology based. Very just if something hurts, something must be wrong. Symptoms are explained as being a result of tissue damage or pathology, and there's an organic explanation for everything. My knee hurts because I hit it on something. My toe hurts because something is wrong with it. And pain is also proportionate to the tissue pathology. So a lot of pain must mean something's really wrong. Not so much pain, things aren't that bad. And I would say it falls short. It's basically showing us, their example is that pain is as simple as a reflex arc. A reflex arc is like the simplest type of thing that can happen neurologically. It basically bypasses any need for cognitive input whatsoever. It's like when a physician taps your knee, you're not thinking and telling your knee to kick out. It's a reflex. It's happening at your spinal cord and not even up in your brain. So it's basically saying, oh, ouch, this hurts my foot, I'm gonna pull out of it. Super simple, not at all going into any of the beautiful complexities that is really interwoven into what pain is and how much the brain is actually involved in this. Doesn't it all take into consideration all of this stuff? Prior experiences, expectations of pain, potentially genetic predispositions, fears and negative beliefs about pain, which I'm sure we can all relate to. How many of you have had clients who come in and said, my doctor told me I could never bend over again or lift more than X amount? All of us hear that all of the time. So negative beliefs about pain that people have societally been exposed to over and over again. People's stress levels, we'll talk about stress a little bit too. Somebody's mood, how sensitive somebody is to pain. Any structural or neurochemical changes that are happening because of pain and stress. And fear avoidance and deconditioning, because you stop doing stuff because you're scared of it. And then your bodies become deconditioned to everything. I used to say on this slide that the biomedical model sucks, but then somebody told me it was inappropriate, so I say this instead now. But I'll tell you instead. So that's a biomedical model. Not too great, leaves a lot on the table. Unfortunately, that's the main pain model that people are taught in school. Very different from what we know to be true. The mature organism model is kind of like the next step of how pain science has evolved. And this is where we're starting to talk about getting inputs from the environment around us, as well as from our own body, to come together and travel to the brain, which is going to evaluate this information. So we're taking information from what our environment around us is like, and then what our own body is telling us, taking all of that information, evaluating it, and creating outputs. Outputs would be a change in behavior, a change in physiology, a change in mood. Could be things like posture changing. You know, when somebody's in pain, you can see them. They're like stiff, walking like this. Like their whole posture has changed. Movements in general changing, becoming very fearful of certain positions, so really changing how we move. And altered physiology, we're having changes in hormone levels, changes in chemical signaling, all of the things that would contribute to how somebody's feeling. And this makes us think of the stress response. I won't bore you with a very exciting deep dive into the HPA axis, but all of this is to say is there is a very predictable and normal stress response that happens from the brain and the body all of the time, no matter what. The brain doesn't differentiate stress, it's all the same input, it creates the same cascade of chemicals and hormones and things happening. And this stress response is also very similar to what happens when somebody's in pain, and they're often perpetuating. So somebody's outside stress and then a pain experience, or pain experience and stress, they work together to have the same exact physiological consequences. And the things that happen when we're in pain look a lot like what happens when we have a stress response. If you think of what the stress response is, it's basically just a lot of sympathetic activity at once. Sympathetic versus parasympathetic, a little refresher here. Sympathetic, that fight or flight feeling. Your heart rate's elevated, your breathing rate's elevated, you're breathing really shallow because you're trying to catch your breath. You're hyper aware of everything. your pain sensitivity is going to change, and there's a lot of other chemical and hormonal things happening too, like your cortisol is going to increase, all of that stuff. On the opposite end of the spectrum, we have basically the inverse of all of that. Everything calms back down, you're relaxed, you're calm. The stress response is perpetuated with that sympathetic nervous system response over and over and over again. And those responses to increase cortisol and all of that stuff are further perpetuated when we're in pain. And the joke I often make is like, why training is so important. Testosterone is a mitigator of how our body responds to cortisol. So if we know a lot of the negative effects of cortisol, like testosterone blunts a lot of them. So the joke I always say is just like, get your clients jacked. They're gonna handle stress better. Big juicy muscles are gonna make you less stressed. That's a sweeping generalization, but it is true if you think about it that way. So this is that mature organism model. It's the first time we're really starting to consider stress, and we're really starting to put it into the equation of pain, but it's still missing some stuff because it doesn't really talk about how much stress. Yeah?
This is kind of like the birth of like gateway theory on pain.
Oh, pain gate theory?
Yeah.
That's even more, that's even more into the biomedical model, because they literally thought that there were certain types of sensations that would open or close the gate to experiencing pain.
Right.
It's kind of the rationale behind like e-stim. So you have pain, you're going to distract your brain by putting something fuzzy on your arm, and the thought is it's closing the gate for your brain to experience pain. So that's where a lot of it came from too. But yeah, kind of in between these two ideologies. So the mature organism model starts getting us thinking about stress, but how much stress, it doesn't talk about that at all, which is very important as trainers and coaches. So that's where the allostatic loading model comes in. Basically just a relationship between the total amount of load or stress an organism or a human can handle, and how well it can manage that load or that stress. If somebody can tolerate the load sufficiently, it's called allostasis. If they can't, you're likely to experience negative symptoms associated with the stress. And loading is all across the board, right? It's physical, emotional, mental, not just the weight we're giving our clients, it's the weight of everything else that they're dealing with in their life. And I think you can overcorrect this, right? You say like, oh, you didn't sleep last night, we're just gonna sit here, breathe, and not train. I think we can overcorrect quite a bit. We have to find that happy medium of how much is still a good amount of training stimulus. But this is important to consider. This is just a nice graphic to kind of show the relationship of all of this stuff that goes into somebody's load or how full their cup is, if you've heard that analogy before. Just taking into consideration individual differences, genes, experience, chronic social and environmental stress, physiological stressors, major life events, and then what the physiological response is, if it's something that is that sweet spot that allows us to actually create adaptation, or if it's too much and you can't adapt to it, just like with training. And then also, like, what is the behavioral response to all of these things? Is it good or is it bad? Is it helpful, or is it something that's going to lead to not so helpful consequences down the line? And the last model is the more, it's kind of like the most sophisticated model, and this comes from cognitive neuroscience, and more specifically, actually, it's very related to a lot of the literature on people with chronic anxiety. And there's a huge overlap with a lot of the physiological and neurocognitive mechanisms that are thought to be going on with chronic anxiety and those with chronic pain. There's a huge overlap between just the symptoms of what people have with those things. But there's a lot to be unpacked here with what people think is happening. So it can be super convoluted, and I want to make it pretty simple. The brain is a predictor. Its job is to look around and figure out all of the possible threat, and then create a prediction based on how you should respond to it. It's why people who've had a lot of pain experiences, their predictive processing is telling them constantly that everything is a threat. And again, that comes back to anxiety. People with extreme anxiety, their brain is telling them that everything around them is a threat or a stressor, and they need to respond to it. So very similar, a lot of overlap here. Again, this I think gets it a little bit more in the weeds than it even needs to be. It's just trying really hard to create a prediction and then act based off of it. And think of it as an energy conservation tactic. As I said before, the brain's job is to keep us alive. It takes a lot of energy to do that. The brain likes to conserve energy to make all of those tasks easier. So it's a lot less of an energetic and metabolic demand for your brain to have this heuristic to be like, oh, deadlifting, that hurt me before, I'm gonna already be predisposed to experiencing pain because I'm making this mental shortcut. Why do I have to divert resources to going through this process again and thinking about it when I can just make this very snap judgment that saves my brain time and energy? That's what a lot of this stuff is. It's a lot of just energy conservation, and heuristics can be good, right? They make us make associations really quick, they make us make decisions really quick, but it can be still quite maladaptive when we're looking at that pain lens. So the example I always give, and I think it's just so easy for us to think of, pain in the past with deadlifts or bending over, the brain's gonna make an assumption or prediction that pain will happen again. We're already getting physiology changes before it even happens, because your body is going through that sympathetic nervous system response, that stress response, to alter our physiology, alter our brain's understanding of what's happening, change our posture, change our expectations. And this is why I think so much of what good rehab or training is just helping people to understand this in some way. You're not broken because you're scared of this thing. It's a really good adaptation for your brain to want to protect you. But we also know we can small dose these things, not only so your body is more prepared, but literally so your brain is more prepared. So when we're doing progressive overload, when we're doing entry points for people who have pain with a certain movement, it's not just for tissue tolerance, it's for brain tolerance too. I think that's super important for us to remember. So this is what I was talking about. Individuals with chronic pain are thought to have impaired predictive processing abilities due to increased sensitization. So that thought that everything is a threat, their ability to predict what their behavior should be or what the outcome is going to be is significantly impaired. And they're getting constant information of increased sensitivity and pain. And their hypothesis, their brain's idea of what they should do, is going to shift to support this information and make sure we're hyper-vigilant, stiff, a lot of tension to prepare for what's happening. All of that to be said, pain is a vicious cycle. And these are things that I actually show my clients because I think it's really important to see it that way. We look at pain, it happens, it sucks, we're scared of it. We have a fear of injury, of course, because none of us want to be injured. And then we're going to avoid that particular activity or movement that we're scared of or that got us injured in the first place. Then we're just generally getting deconditioned. Not only is the area deconditioned, but your whole body is. Like, think of how often if something hurts, the motivation to move at all just goes out the window. And then from there, we're getting increased weakness, mental deconditioning, and depression. And that cycle just continues. And this is something that I think we've all experienced. And I literally just did last week. And it's so important to remember that this is what's happening when people are going through these like pain cycles that they feel stuck in. It's not that they're broken. It's not that there's something wrong with them. It's something so much deeper than that. That, again, even just talking through this stuff in a very, digestible way helps people a lot. This is another one I like a lot, kind of comparing what happens when we catastrophize versus not catastrophize. We have an injury, of course we have pain. Somebody who does not catastrophize or put a lot of fear behind it, they can confront it and recover. The vast majority of us are going to go through the opposite. But we're going to catastrophize and freak out. We're going to be fear of pain or the movement or re-injuring ourselves. We're going to avoid, we're going to become hyper-vigilant and aware of everything around us. And we're going to have muscle reactivity and tension to everything. And then there lies the disuse, depression, and disability that just continues us in that loop. Who's done that before? All of us, right? Who's done this? Okay, a couple times I like it. I think I have a couple times too, but I usually end up on the other side. I think, again, it just shows you how human this is, right? I think that also helps me if we can humanize the pain experience and stop making people feel so bad about it, I think that's really helpful too, because, and this could go into so many other components, like it's the same thing with nutrition. Yeah, it's really hard to get good at nutrition because your body, its job for so long has been to find everything that you can and hold on to the nutrients because you don't know when you're going to get it again. So humanizing recognizing why this stuff is hard is helpful. Like, yeah, your brain wants you to be like not so cool with things that hurt because it's trying to keep you alive. So it's normal for this stuff to happen, but we have to add in that extra layer of confronting and overcoming things. So some important pillars of understanding pain. We have to remember that having pain is normal. I often tell people, just like I can't prevent you from leaving the room and stubbing your toe, I can't prevent you from never having pain again. Just never gonna be something that I can do. But we can help people become so resilient that if they do experience pain, they're mentally and physically better able to handle it, which is important. Tissue injury can be one component, but it's far from the only thing that matters. And after an injury, tissues heal, but muscles learn, and they readily develop habits of guarding that outlast the injury. This comes down to a lot of things that we see people with disc herniation. Who's ever experienced a disc herniation? Just me. Rowing is a great sport. Not fun. So who's worked with people who've experienced disc herniations? A lot of us. So what a lot of people don't know is most discs, like 90% of them, heal within 12 months. Always, they heal. How many people have you had who've had pain for decades? A lot of people have pain for decades after a disc herniation. A lot of that is to be said, of course, about, okay, their doctor told them to never move again. Their doctor said, wow, I can't believe you walked in here, you have the spine of an 8-year-old. Or all these crazy things that physicians tell people. And then they also, more often, stop doing a lot of things that they're fearful of aggravating their back, and their back tissues aren't ready for loads. So that's an example of things that, like, guarding that outlasts the injury. And then even the anticipation of pain can compromise function and performance. It centers on everything that we just talked about. Thinking about pain, expecting pain, really can change our performance, our function, and make us very fearful. So second guideline for successfully managing pain, kind of regardless of who we are and what the diagnosis might be, meeting physical activity guidelines. So this is something where it's totally in our wheelhouse, understanding how much people should move. And it's also something that contributes a lot more to the likelihood of experiencing pain. I think it makes obvious sense, but it's nice to have some literature to back it. And also, what I really like about this, is we've all encountered this, had somebody in pain and you don't know what the hell to do with them. I've for sure experienced this as a rehab provider, where I'm not really sure where to start. I can feel very confident at the bare minimum, lowest hanging fruit. If they're not meeting physical activity guidelines, that can be something I suggest that we implement. It might not be from 0 to 100, but I can be very confident that that very small intervention point is going to get us moving in the right direction. So I use this also as, like, quite frankly, when I'm just like, I have no idea what to do with this person, or I don't know where to start, or I've never seen this type of case before. This is always a conversation that I have where I'm trying to make sure that somebody is meeting the guidelines and knows what they are. So the PA guidelines are pretty simple. People should move more, sit less, not necessarily that sitting is bad, just changing position is important. Recommendations for adults for aerobic activity, 150 minutes of aerobic activity a week. They say or 75 minutes of vigorous. I don't really like that because they're two completely different energy systems. So I say and if you're lucky, or a little bit both. But I don't think it should be like, oh, you did 75 minutes worth of HIIT classes, you're good. Steady state aerobic work is also very important too. And then also twice a week, hitting all major muscle groups for strength training. So pretty simple, 150 to 300 minutes, so the more the better, they say, which makes sense for this. For aerobic work, 75 to 150 minutes of vigorous aerobic activity and 2 days per week of strength training. Who hits these? Who is the limiting factor here, the cardio? Yeah, all of you meatheads, okay.
Always.
Same. It's funny, I talk about this a lot with other coaches where it's like very real, the realization like, oh, we actually usually don't meet these guidelines. So a little reminder for all of us too. And so, across the board though, like pretty reasonable things to hit, right? 150 minutes of aerobic work. For a lot of our clients that might mean a brisk walk. For some of us that might also mean a brisk walk too. Like I would consider anything just like steady state to be important here, and it's a great starting point. So sprinkling that out through the course of 5 days, like 30 minutes at a time, sprinkling it out through the course of 7 days, even less. It's pretty sustainable if you think of it that way. And then twice a week of strength training. We all hit that. We're all in the gym a lot more than that. But pretty simple things to hit when you really think about it. However, there's a startling amount of people who do not hit those guidelines. Yes?
What would qualify as vigorous aerobic activity in your definition?
Probably getting your heart rate out of the aerobic zone. So for a lot of people, like the buzzword right now is zone 2 stuff, so probably anything beyond that. I still consider a lot of zone 3 to still be pretty aerobic building too. But more of, you could also think of it as like conversational pace versus you're panting a little bit more. So like steady state jogging where your heart rate's at like 140 versus faster running where you're in like the 160s, something like that for kind of our age demographic or for people who are in our level of fitness.
What about like for someone that's 75 plus?
Yeah. So that's where I would probably just start on the low end and only really care about getting them walking or doing some sort of steady state activity. Because what becomes challenging for older adults is we have tissue demands to consider for anything that's higher intensity. Because things that are higher intensity are usually going to be a little more plyometric, moving a lot faster than maybe they're used to or quite ready for. So I would always start with let's nail the steady state, the more aerobic stuff. For some of our older adults who are quite deconditioned, just walking is going to be really good for them. As they get fitter, get them a little ruck, a little backpack with some to add some load to it, which is a great way to increase the demand without really changing too much or making it really vigorous. You can also, again, a lot of this is dependent upon somebody's fitness level. So just because for us, vigorous activity might not be getting on a stationary bike and moving the pedals a little faster, for them it might be. So you could sprinkle in dosages of those. I love to utilize cardio and even like plyometric exposure as my movement prep for people. It's gonna look different for everybody, of course. For an older adult, again, plyometric might just be here, or like getting out of a chair really fast. But it's a great way to prep the tissues, get small bite-sized dosages throughout the week, actually get them warm, do something that's with them instead of like, hey, go on the bike for a little bit if you have the time, or sometimes we don't always have the time. And it's really building tissue qualities that they probably don't have. So a cool way to integrate that. This shows us that, unfortunately, about 25% of Americans meet physical activity guidelines over the age of 18. It's wild, right? 25%. That means we have so much we can do with people because chances are that percentage is similar for people who come in here and have pain. A huge portion of this is a conversation of the importance of movement and physical activity. Low-hanging fruit for people, for ourselves, it's pretty wild. So then this brings us to the relationship between physical activity and pain. So again, this is stuff that I think logically makes sense, but it's nice to see some literature to back it. This is an observational study. So again, there are limitations to this type of study. They're looking at a bunch of information rather than testing things between each other. So it's not as high level of evidence as like what we talked about earlier. Like a systematic review where it's looking at thousands of studies with control groups, placebo groups, and different interventional experimental design. This is looking at a bunch of data after the fact. Still valid and valuable, but that's just my disclaimer. It shows us the relationship between physical activity and pain in adults. So the findings, the odds of engaging in physical activity decrease in a dose-dependent response to frequency and intensity of pain when compared to no pain. All that says is if somebody was moving more and more active, they had a dose-dependent, or depending on how active they were, more or less relationship to having pain. In this case, less pain. The more active they were, the less pain they had. Individuals who met physical activity guidelines, both strength and aerobic, demonstrated twice lower odds of reporting pain when compared to those who are not meeting physical activity guidelines. I don't remember the exact number, I have it in the notes here of how many people were in this study. It's like 30,000 or 50,000 or something crazy. So really prolific numbers here. Again, is this perfect? No. Are they really doing very strict study design? No. But we're getting a lot of data about a lot of people and simply comparing, do you meet PA guidelines or not? And a huge questionnaire and medical history of past experiences with pain. So people who move more are less likely to experience pain. Not that they're never going to experience pain. Exercise is not a perfect intervention, but I'd argue to say it's probably our best bet, and all of the other positive downstream effects of exercise just make it should be the gold standard. And this, comes back to an explanation of why that might be true. There's obvious reasons, of course, people are probably healthier if they're more active, their body composition might be better if they're more active, so maybe they have less comorbidities. Some of those things that make sense why this would be true. But then also what we've talked about earlier, we have some sort of pain, and we have this whole cascade of events happening again. We stop moving regularly, we're decreasing the loading of tissues become more deconditioned over time. The brain is going to conclude that tissues that are at a higher risk of injury, because they're scared of them and they have heightened sensitivity, that means something is really wrong. We have increased threat, which is that sympathetic nervous system response. We're getting protection mechanisms, higher levels of pain, protective muscle tone, altered movements, all the stuff that we talked about. So it makes sense why those findings would be there. There's a lot of mechanisms at play here, but this makes sense. And this is something that is becoming a lot more of a topic that I find super fascinating. And understanding the relationship between obesity, metabolic syndrome, and pain, and what the implications are to the musculoskeletal system, that there's a lot more of a relationship with people with these underlying conditions and really common musculoskeletal conditions that go beyond just like, oh, you have tendinopathy because you used your knee too much. 25% of people are meeting physical activity guidelines. I don't think people are using things too much. I think we're not using them enough. This is a really cool study. There's a lot more of these things coming out. This is about obesity, metabolic syndrome, and musculoskeletal diseases. Common inflammatory pathways suggest a central role for loss of muscle integrity. I'm going to show you a little blurb from it. This basically just means there's a relationship between obesity and metabolic syndrome, meaning diabetes, or kind of on the cusp of diabetes, or other hormonal considerations, and the experience of the most common musculoskeletal diseases, which are osteoporosis and osteopenia, tendinopathies, and arthritis. Suggesting that there is a common inflammatory mechanism happening to the tissue that is present with metabolic syndrome and obesity that we also see in the degradation of bone and tendon. So is somebody's knee tendinopathy, again, because their knee sucks and they used it too much? Or is it because they have a lot of circulating things happening hormonally and chemically that's degrading the tendon health because of underlying, basically sedentary health problems? This also shifts the goalpost a lot for what the hell we're trying to do with people. If you're not a rehab provider and you don't know necessarily the intricacies of tendon rehab, who cares? Get them moving in a tolerable way, because chances are it has a lot more to do with these inflammatory pathways than just doing like a very specific tendon rehab. Does that make sense? This is a lot. I'm going to just read a little bit of it. This article is fascinating. Like, I highly recommend going through it. My favorite part of this: muscle is highly plastic, undergoes regular remodeling, and is responsible for the majority of total blood glucose utilization, which when impaired leads to insulin resistance. Furthermore, impaired muscle integrity, defined as persistent muscle loss, intramuscular fat accumulation, or connective tissue deposition, meaning you're getting connective tissue into the muscle instead of juicy muscle fibers, so like not good, is a hallmark of metabolic dysfunction. In fact, many common inflammatory pathways have been implicated in the pathogenesis of interrelated tissues of the musculoskeletal system: tendinopathy, osteoporosis, and osteoarthritis. There isn't a specific protocol for any of those conditions. It centers a lot more on restoring muscle mass, getting somebody's muscle composition better, and getting their overall health better. Getting them to walk more so they don't have insulin resistance. Getting their body composition to improve so they're utilizing substrates better and not having this impaired glucose utilization. We can all impact that, whether you are a DPT, a chiropractor, an ATC, or a strength and conditioning specialist. It doesn't matter what you are. We literally can all do that. That's in our job description. I'm super excited about this. I think this is just the coolest study. So an important takeaway from this: inflammatory pathways seen in common MSK conditions are the same we see in obesity and metabolic syndrome. Common musculoskeletal pain is a metabolic issue beyond a tissue issue. so much more than just being something wrong with your tissue. It's a holistic, whole person health problem, and not just, okay, we're gonna just do isometrics and eccentrics and only focus on that. There's so much more to it. Oh, we just said that. No, it's supposed to say finding an entry point. Okay. Well, did this not go in the order I want? One moment. Huh. Okay. Well, this, we'll just, on the fly here, this is point 3 is supposed to be finding an entry point. Finding an entry point is one of my favorite things to do as a provider because it's all about taking the movement that somebody is the most scared of and reverse engineering it to find a way for them to start finding a modification or a way to get there that doesn't flare them up. If we can create a positive experience with the thing that got somebody hurt in the first place, or a positive experience with the thing they were the most scared of, we have won. That is huge. If you can get somebody to leave here doing something that they never thought they could, or they've only associated it with being painful, like that's it, that's the bread and butter of helping people overcome pain. A super common thing, of course, is deadlifting. How many of you guys have had people who come in saying they're terrified of deadlifting or that's how they hurt themselves in the past? Or us, ourselves. Yeah, that's okay. This is a safe space, it's fine. So many people, and if I have somebody who comes in with a flare of low back pain from deadlifting, and red flags are ruled out, right? They're not like walking in, dragging their foot behind them, they have sensation, they didn't have a traumatic event happen. I'm finding a way to get them hinging day 1. It might not be a loaded barbell, it might not even be with weight at all, but I'm gonna find a way to get them to do some form of a hinge pattern day 1, because if I don't, all I've done is perpetuated the idea that this is dangerous. So it could be the most basic rendition of a hinge movement, but not only am I starting to recondition the tissues, but I'm reconditioning their brain. It might be something as simple as here, or here, or even just holding an isometric and getting them to feel, oh yeah, I feel like my glutes and my hamstrings, not my back. Or getting them to feel back muscles and letting them realize like it's not your spine, we have so many muscles back here, it's okay to feel stuff here. But finding a way for somebody to initiate that pattern as soon as I possibly can. It might be a bridge, it might be a hip thrust, it might be kneeling and just coming back and coming forward. It might be even less than that, because it's all they can tolerate, but I'm gonna find what that thing is, and I'm gonna make sure that they feel really successful with it. I found that early on in my career, and of course sometimes these situations are warranted, but I used to go so far in the other direction and only focus on the stuff that felt good. Be like, okay, well, we're gonna get back to that when we're ready. But all I'm doing is still making them think that they're never ready, or they're not ready, or this is too dangerous to do right now, so we're gonna do only safe stuff right now, and then we'll do the thing that was so scary and bad. So if you can find that little bite-sized way to start dosing it, with good frequency too, because none of these things that I just showed you are too much of a stimulus to irritate them. Small movements, things that are really safe. I love isometrics for that reason. This is the safest form of muscle contraction you can do. I always tell people, what do we initiate post-operatively first with muscle contraction? Isometrics. This is safe for a new shoulder, it's safe for you. That makes people calm down a lot. Like, oh, okay, it's safe for me to be in these positions. So that's why I love to start with isometrics. It's super safe. You start to be able to find a way to stress the target tissues that you care about, and you're not gonna flare somebody up. We're all gonna flare people up. I've flared people up plenty of times. Isometrics probably aren't gonna do it, so you can rest assured knowing that you're not gonna flare people up. And then point 4, progressive overloaded load management. This is stuff where I mentioned in the beginning, you know, rehab providers suck at this part. Trainers and coaches are so good at this part. Rehab providers take away, usually. Strength coaches are about building people back up. That's why I think we need to learn a lot from each other. This is something that's, I always say to, I say this in some way to my clients all of the time. In the absence of red flags and trauma, most pain is due to a combination of lack of preparedness, exposure, and capacity for the demands placed on the body. It's usually because of all of this that somebody has pain or gets injured. It's not that there's something wrong with you, or what you did was unsafe, or your form was bad, or your knee just sucks, or my mom had a bad back, so I have a bad back. All the things that we hear, or sometimes think for ourselves too. It's so much more than that. It's usually something, just all of these cluster of things happening, where we asked our body to do something it wasn't quite ready for. Or maybe something that it would have normally been ready for, but we've had a really shitty week, and now our stress levels are through the roof. And we just asked ourselves to do something that we did when conditions were perfect. That happens a lot too. And I like to think of reframing the term overuse to underpreparedness when discussing a potential contribution to pain or injury. This also takes it makes it a little bit more actionable, I think. That we just think that our bodies deteriorate, and if we use them too much, things suck. Well, then what can we even do except rest and do nothing? It's not super motivating, not super helpful, not at all aligned with how tissue physiology works. But that's still the message a lot of people get. And as I mentioned as well, vast majority of Americans are not meeting physical activity guidelines. Their knees don't hurt because they're using them too much. Their knees hurt because they're not moving enough and they're not getting any nutrition to their joint and building up juicy muscles to protect them against the struggles of life. Underpreparedness is different. That makes us realize that there's things that are actionable that we can do to prepare for, and that we have a lot more of a say in our pain and injury. And it also shifts the feeling of, pain is not the only measure I want to look at with people. I want to look at function too. This is another thing that I've shifted from very earlier on in my career, and honestly just things that we're taught in school. We're taught to ask about people's pain on a 0 to 10 scale, like every waking moment. Somebody walks in, 0 to 10, how's your pain over the weekend? And we're making this the forefront of people's mind. That, okay, this is all about pain, pain only. So their only understanding of healthy versus unhealthy is if I'm healthy, I have 0. If I'm unhealthy, I have pain, whether it's a 1 or a 12. We all know we can be healthy and have pain. I'm healthy, I had arm pain. Something else wrong with me. I'm not unhealthy because of that. It doesn't mean that in the absence of pain, I'm suddenly perfect and everything's fine. We need to help people realize that it's totally normal to feel somewhere along that spectrum and shift the goalpost to caring about function. So I've stopped necessarily asking about pain all of the time, and I'm more like, what did you do this weekend? What did you do this weekend that you couldn't do last weekend? Oh, that still kind of bugged you? Okay, cool, let's attack it. It's a completely different conversation than immediately bombarding somebody with a pain question. And it's not the load that breaks you down, it's the load you're underprepared for. This is where load management and volume management comes into play. I don't really even like the term breaks you down anyway. It's kind of negative. But it's a good way to think of it. It's not that what you did was wrong, it's not that the weight you lifted was bad. Your body just wasn't ready for it, and we can make it ready. That's what all of our jobs are. So you guys know this stuff too. What is progressive overload? It's the hallmark of resistance training. It's increasing load or training stress to increase neuromuscular demands to further create an adaptation. It's the hallmark of resistance training, but why is it not often seen in the rehab setting? I think it's a little bit different here. You guys do all of this stuff. But by and large, unfortunately, I think sometimes we have to remember that we're only seeing such a small snapshot of what the healthcare field is like because we're in settings like this. I talk to my team about this all of the time. We're in a bubble. We're in a bubble of people who care, people who have longer time to spend with people who have this as their office instead of an exam room and a treatment table. We have so much more access to getting people to move. We have to remember that that's still not the case for most places. So it isn't the hallmark of rehabilitation in most places. And what about load management? This takes into account all the stressors, not only training stressors, but the stuff that we talked about before when implementing training or rehab. So that's nutrition, sleep, physical activity, training, work stress, life stress, all of that stuff. So those two components are so important because it's about the dosage, it's not necessarily about the movement. How much is too much and we get a flare up? How much is not enough and we don't get any adaptation, so we're doing clamshells forever? What's the sweet spot in the middle? There's a time where maybe that's totally appropriate. We have to graduate from that at some point. But there's also a time when we can get maybe too excited and push somebody too soon, and it causes a flare up. But I always tell people, because it's really easy to get freaked out yourself in that moment when you've just literally caused a flare up. Who's done that in like a training session? Oh yeah. I've done it when I've had students shadowing me, like, cool. But it's a great way to, in real time, appear and still stay very calm, So they do not pick up on you being freaked out by you just flaring them up. And I always tell people, and this is true, a flare-up is a data point. All it does is give us information. This was too much for us today. Now we know that. Now we can try something that's maybe not as intense and use this to our advantage of understanding where the ceiling is right now. And now we also know what we want to be able to accomplish. What we were trying to do today has just become our goal. That is so different than panicking because you flared somebody up and immediately pivoting to something that's really, really low level to make them feel again like something that you just did was too much and too scary for them. It's all about how we approach this stuff. It's not perfect. We're not always going to be that attuned in real time, but I think it's really important to think that way and to at least try to calm the person down and show them like, cool, this gave us information. We're going to get it to calm down a little bit today, and now we know this is our goal for us, which is huge. Progressive overload and load management and rehab, or just dealing with pain and training. We need to expose our clients and patients to enough of a stimulus to create an adaptation. I would say the vast majority of rehab doesn't quite get this. Gradual exposure of a greater stimulus creates tissue and psychological adaptation, which is what we talked about earlier. We get your tissues ready and we get your brain ready for more. And then, but really it's the Goldilocks amount, like how much is enough rather than too much, too little. We don't have a perfect answer for that, but we do have some guidelines that can help steer us. And this is where having that relationship with your client is so important, where you can be honest and say, some of this we have to try. Sometimes we're gonna get it wrong and it's gonna be a little bit irritating, but we know what to do to dial back and to make sure that we maybe remove something that's a little bit too much and start with something that feels better. So we have to be honest with our patients that a little bit of this is like, we do need data points. We do need to know what is too much and what is too little. We must also take into consideration all stressors in training and rehab, which is what we're talking about. So what does that actually look like? These are some things that I talk with my team about, like this is a way to think of load management, volume management, and to make sure we're creating an adaptation. Typically looking for RPE 6 to 8 for all sessions that I'm working with somebody. This is in training and in rehab. If I'm not getting somebody a high enough RPE in my rehab session, I am definitely not doing anything to change their tissue and their brain's ability to tolerate what we're trying to get them to tolerate. Is that going to look the same as an RPE 8 in a training session? Maybe not. Maybe with somebody with an acute flare-up of low back pain, a single leg RDL ISO hold is an RPE 8. And it's not too much because they're not feeling it in a threatening way, but it's really hard when they're shaking. So how do we get that RPE 6 to 8 sweet spot zone in all of our sessions? That's what we should definitely prioritize. That's why I also like doing a warm-up or a movement prep that's something a little bit higher intensity because I'm starting the session off, getting it going, and not doing, kind of rehab purgatory of a million mobility drills and things that are honestly just downshifting them before they start doing the work. And understanding of tolerable discomfort versus alarm bells pain. This is where that 0 to 10 scale can come into play, but I use it more for grading like how they're feeling in the moment. It's tissue dependent, it's person dependent. We all have people who freak out over the slightest bit of pain, so you might have to adjust a little bit. But think of that like 0 to 3 sweet spot of, okay, this is tough. I feel a little bit of something, but it's not making me change my facial expression, guard, change my position, or be fearful. It's probably an adaptable amount of discomfort. Beyond that, we might be getting more into the territory where we're just gonna get flared up and that's not really helpful, so let's find a modification instead. Again, not perfect. Everybody's so different. We all have people who, they'll be like, oh yeah, this is like a 10, and their little fingers look fine, like they're not in any pain, and their awareness and their hypervigilance makes them think so. Post-session soreness and discomfort, so does it persist for more than 24 hours, is a general rule of thumb I like to give. Okay, we did deadlifts, your back kind of got a little irritated, nothing like a 9 out of 10, but maybe like let's say a 5 out of 10. Did it persist at that level for 24 hours after your training session, or did it calm down? If it calmed down, it's probably that this is still an okay thing for us, but we might need to gradually build back up to it. If it got too irritated, we pushed it a little bit too much that day. Simple stuff there. And then acute to chronic workload ratio. This is something that I'm taking a general principle of instead of getting into the weeds about it, but it's cool to see some numbers to see kind of what it means and how we think about what we're giving somebody versus what they've already been exposed to. Like, am I suddenly giving somebody a training session that is significantly higher in volume and intensity than anything they've done before? Or am I logically progressing them to where they are today to maybe do a little bit of an increase, but not so much that it's wildly different than what they've been exposed to? Does that make sense? So Tim Gavitt, he's an Australian researcher and physio, I believe. He's all about understanding like that relationship between somebody's acute workload, like what you're giving them today, versus chronically what they've been exposed to. He's like the load management guru. Pretty cool stuff. He's kind of hard to understand though. So these are using numbers. Again, this is just to illustrate the point. So somebody's chronic workload, let's look at like 4 weeks of somebody who's been training. Their acute workload might be this week, what you're trying to get them to do. Running is really easy to use for this because the numbers are easy. Let's say somebody for the past 4 weeks has been averaging mileage, or we're using kilometers here. Week 1, they've averaged 25 kilometers. Week 2, they've averaged 30. Week 3, they've averaged 32. And week 4, they've averaged 27. So overall, over the course of 4 weeks, 28.5 kilometers is what their body's been used to doing for running. Say this week, we're doing 43 kilometers. All you have to do is divide those two numbers and see that that turns it into a ratio or a decimal of 1.5. Over 1 means that you are overreaching and getting beyond what would be a reasonable workload stressor to add into somebody that week. So this is a huge jump in volume and something that is so far off, you can even see it without doing the calculation. 43 is much bigger than 28.5. There's a huge disconnect in how much you're prescribing somebody week 5 versus what they've just been exposed to for the average of 4 weeks. Gavitt reports an increased injury risk with an acute to chronic workload relationship of greater than 1.5. And it's not perfect. He's looking at a population of, I think, like cricket and rugby players in Australia. But it is interesting that there is a relationship between that. A really general rule of thumb that is suggested in the literature is thinking of about 10% increases of volume or intensity week over week. It's really hard to do this because you suddenly realize how much we probably push it, where, especially with running, like I think of this example, people who run a half a mile, they feel awesome. And then the next time they run a mile. They just increase their workload by 100%. A lot of people who start running do not understand why it hurts them so much, why it's so hard. We have these arbitrary ideas in our head that a mile is easy, it's not very much, but if you literally double what you've just done and you haven't been, I don't know, hopping on one leg over and over again in a really long time, because this is what running is, it's probably going to be a lot. So this gives us really good guidelines for helping to progressively overload and progressively increase volume and intensity without making huge jumps that in our heads actually don't seem like a big of a jump, but tissue physiology-wise, it's a pretty big jump. But at the end of the day, our goal is to improve an individual's ability to tolerate training load, because it's never going to be 10% perfectly all of the time, but just kind of keep that idea in your back pocket that especially when somebody is brand new to something, be a little bit on the conservative end for how we're increasing their volume and intensity. With running, something I'm really passionate about is trying my hardest to not take running away from somebody, even if they have pain when they do it, because I'm trying to find that sweet spot of how much they can tolerate before they have pain. But it's still very important for us to consider these jumps in workload. 10% is a lot less than we think. It's easier to think of with strength training, right? Like a 10% increase in weight, yeah, you're gonna feel that on your back squat. But with running, it's really hard for us to think of that. The last point here is non-diagnosis driven care. This is something I talk about all the time, and again, I always want to preface this to say, like, it's not that I think diagnoses never matter, because there's times when they absolutely do. There's red flag symptoms that warrant referrals to other providers, like thinking of the low back pain, for example. If somebody comes in to see me as a physical therapist, it's my job to refer when there are symptoms that fall out of the scope of my practice. Somebody comes in and they're dragging their foot behind them, they can't stand on one leg, they have sharp, shooting, debilitating, razor-like pain down their leg, they have changes in bowel and bladder function. or they had a very specific traumatic mechanism of injury, that's out of my scope and I have to refer. In the absence of those really, really serious and obvious things, we all have a lot more wiggle room of what we can do with people. So if we're not seeing that stuff, it's hard for me to really care about what exact tissue is implicated, because it's just like their back and their hips and their whole body that I have to make a little bit more resilient. Looking at knees, there's so many diagnoses going on with the knee, and what's the difference between an MCL sprain, LCL sprain, patellar tendinopathy, patellofemoral pain syndrome, knee OA, jumpers or runner's knee, IT band, Plicus syndrome, bursitis, all stuff that people really hold on to when they get this type of diagnosis. Who cares? Make the knee a better knee and the human a better human. Again, without red flags in the knee, without it swollen like a grapefruit and they can't stand on it, or they literally just got in an accident, it doesn't really matter what the tissue is. It matters what is their current function, where do they need to be, how do I fill the gaps, how do I give the knee what the knee needs. It needs to bend, it needs to straighten, it needs to produce force, it needs to absorb force. Okay. All of those conditions need to do that. Every knee needs to do that. Find their limitations, understand their goal movement, sport, activity, or hobby. Find all the things they can do without pain, make them feel like a badass, give them those things. Find the hardest version of the thing they currently have pain with, their entry point, start there. And then progressively overload them and manage their load. This is irrespective of diagnosis. This is everything. We can all do this. I love these. This is a group. Reload is a very similar setting to this and to Old Bull out of New York, like hybrid training and rehab. Each of their team members had a really cool thought for saying something. They had like a Just Saying series, and it's about different misconceptions in our space. So your knee hurts when you run 30 minutes, but not when you run 25 minutes. It's not a knee issue, it's a capacity and endurance issue. You don't have a knee problem, you've just maybe pushed it beyond what your knee was used to being able to tolerate. Your knee hurts when you do single leg squats, but not when you do double leg squats. It's not a knee issue, it's a strength and stability issue on one leg. Your knee hurts when you go down a flight of stairs, but not when you go up a flight of stairs. It's not a knee issue, it's an eccentric control and strength issue. Your knee hurts when you train legs 4 times a week. Who does that? It doesn't hurt when you train legs twice a week. It's not a knee issue, it's a programming and load management issue. Your knee hurts on landing after jumping off a box, but not when you jump onto a box. It's not a knee issue, it's a deceleration and a force absorption issue. I don't care if the issue is their meniscus, their patellar tendon, one of their ligaments, again, without any red flags or anything that's unstable or dangerous. Your knee has to do all of those things, regardless of what's going on with it. Overrated factors for pain are tissue damage, posture, and biomechanics. Underrated are too much or too little volume, intensity of movement, general health, thoughts, beliefs, emotions, God, physical activity. I like that. So that was zooming out, looking at those general principles for guiding your decision making for people dealing with pain, regardless of who we are and what the person is dealing with. So it's looking at those big picture things, understanding how complex pain is, helping people meet PA guidelines, finding an entry point, really making sure we're understanding load management and the appropriate stimulus to create an adaptation, and then not getting hung up on a diagnosis when it doesn't really matter. Those are the main principles there. So now we're zooming in a little bit more. This is my favorite. The way my brain works, I love to find patterns in things. I love to take information from what somebody is giving me and then find the relationship between all of those variables and have that help me guide in what I would like to do with that person, or gain an understanding of why they might be experiencing what they're experiencing beyond that your knee hurts because you're old, or you did too much, or there's a meniscus tear. Like finding all of the parts of the puzzle that give me a pattern. This is when taking a history too. So these are things that I like to think of. When I'm taking a history with somebody, I'm kind of putting people into boxes in my head. Not that it's perfect, nobody fits in a perfect box, but it starts to guide me on, okay, there are traits or there are components of a history that are going to lead me to say, ooh, this sounds kind of like this is going on. And that really helps me in real time be able to, kind of no matter what, if it's something that I've never seen before, have an idea of where to start. Like I mentioned earlier, we're all going to encounter people where we're like, I have no idea what's wrong with this person and I don't really know what to do, but patterns can help us. So a question I like to ask myself when I'm getting a history, when I'm watching somebody come in, is this person a catastrophizer or are they a confronter? We talked about that image. Is this somebody who is going to freak out at any incidence of pain and go down that downward spiral? Or are they somebody who's a little bit more likely to address it head on and be kind of bought in and understanding of the idea that pain is complex and we don't have to be scared? So I'm trying to think in my history taking or even just watching somebody what bucket they fall into. What is their understanding of their pain? That's a question I'll often ask. Somebody comes in with back pain that they've been dealing with for 10 years. Okay, what has somebody told you about why you have back pain? Well, what has your physician told you? What have your PTs talked to you about? What have you done for it? I want to know what they think is going on or what somebody of authority has told them before. If somebody with authority before has told them that they have back pain because they have the degeneration of an 80-year-old, or it's because they have a disc herniation, or it's because they had a discectomy 20 years ago and were told to never bend over again and then they did, I need to know what they've been told before. It's going to help me understand kind of what category are they going into. Are they a catastrophizer because everybody who's ever talked to them about their pain has catastrophized it for them? Or are they like, yeah, my back flares up time to time, but I actually feel a lot better with movement, but I don't really know what to do with my program. Might be more of a confronter. Might be somebody who's a little bit more open to the idea that pain catastrophization is what makes it worse instead of potentially addressing it in a way that's manageable and tolerable. What have they been told about their pain is what I just talked about. Do they catastrophize and avoid movement? So is this somebody comes in who had a flare up after deadlifting and they haven't done anything in 6 weeks because they've been too scared to move? Or is it somebody who comes in and they're like, yeah, my back flared up with deadlifting, but I've still been able to go for walks, I can still do some upper body stuff, but I really need some help on knowing like how to get back to deadlifting. Might be more of a confronter too. And then of course, the obvious one, do they confront it head on? Are they okay with addressing it? Do they know if they want to get back to this movement? Or are they now thinking that it's off limits? Nobody's perfectly in either category. We can kind of go back and forth, but it's a general distinction that I like to give in my head about who I'm working with. Overdoer versus underdoer. I think of this in terms of, am I dealing with somebody who they're going to go to RPE 10 for everything ever. They're going to go to 10 out of 10 pain, and they're going to redline every training session. Like somebody who goes to Barry's boot camp and sprints every day, or who does CrossFit 6 times a week and never does anything kind of recoverable or anything in that aerobic zone. Or are they an underdoer? Are they not meeting physical activity guidelines? Are they really sedentary? Are they not doing a ton of activity? Are they somebody who doesn't quite understand that movement is pretty important for just day-to-day life? Some things that I'll talk with these people about or just try to glean from knowing them. Are they a high-stress, high-performing individual? It's going to make me think more on that overdoer. I work with a lot of people like business owners, people who have really, really stressful lives, and it's 0 to 100. Everything they do is 1,000% effort. They don't sleep. They're the type who kind of glorify the grind a little bit. They're over-caffeinated, which sometimes I am. And their training reflects that too. They're like, okay, so I do CrossFit 6 days a week. I run 20 miles a week, and I do sprints 4 times a week. And then I have a private Pilates class every week, and I have a yoga instructor come over, and they're doing everything. I am not about to gatekeep people and tell people to not do activity, but there is an amount that's recoverable, and there is an amount that might not be. So that tells me a lot about them. Or are they not meeting the physical activity guidelines on the other end of the spectrum? Do they have a sedentary lifestyle? Do they redline every training session? Have they never heard of anything of a heart rate below 180? Are they seeking recovery modalities rather than looking at adjusting their program? Is it somebody who kind of wants to do more of the passive care, might be on the underdoer side of things, or it's somebody who's maybe open to adjusting their program and finding what works? And then is it a force absorption or a force production issue? This is one of my favorite parts of the pattern. Because just like we talked about with all those examples from reload for the knee, so much of pain is not because there's something inherently wrong or bad with the joint. It's more that there might be some lacking capacity that's pretty important for the joint to be able to do. And I like to categorize these things as force absorption versus force production issue. Our joints have to do both, our muscles have to do both. Is it worse when they go fast? It's like more of a force production issue. Quickly being able to produce force versus softly being able to land in an absorption way. What about when they go slow? What about when they land, when they pause? What phase of movement is bothersome? Is it on the way up from a deadlift? Is it on the way down? What is their natural tendency? Are they springy and super athletic and agile? Or are they like me and they sat down for their sport and just had to pull a lot of weight all the time and they're a little slower, a little bit more muscular based? Everybody kind of knows their tendency, right? Or you can watch somebody and see pretty quickly what their tendency is. Understanding this gives me so much information about why somebody's having pain in the movement. I have runners all the time who only have pain when they run slow because they're tendony and they're springy and they're fast, but their muscles aren't used to absorbing force when the speed slows down and force absorption increases exponentially because they're spending more time on the floor. They're used to getting off the ground really quickly and using like that elastic response of a tendon and not used to having to maybe absorb it with their muscles. That tells me a lot. Or conversely, is it a runner who only has pain when they go fast? Because maybe they're only used to running slower or at a more moderate pace. They don't have a lot of tendon quickness or stiffness or elasticity. You can't jump very high when they've never even really trained it. So then they start to do sprints and they wonder why their Achilles feels terrible because they've never exposed it to that before. So this goes way beyond, is it an Achilles problem or is it your tendon's ability to quickly produce force and be stiff and utilize that like sweetness of all the free energy of what a tendon is supposed to give us? Or is it something where your muscle isn't used to having to absorb that force because you haven't trained it in that way? And then what buckets are already filled? And what buckets do I need to help them fill? What are they already really good at? What do they do in their training? What do they feel awesome with? What are they super successful with? Versus what do they not get any exposure to? And maybe why does that mismatch explain or add to the explanation of their discomfort? What are they rock stars at? What do they already do a great job of? What training modalities do they already do? What energy systems do they already train? And where are they lacking? This is where we can also, within a session, sprinkle in things that people are really good at, and then give them the things that they're not as good at. If we spend our time doing the hardest things and the things that somebody sucks at the entire session, they're gonna feel pretty defeated. So sprinkling in things that they feel really awesome with is huge, and same thing with a pain perspective. Sprinkle in the things that don't bother them, and then spend some time on things that are really still pretty tough and pretty bothersome. All of that is to say, when we're looking at people and understanding their history, understanding their story, I always encourage people on my team, again, this is from a very like principles-based idea, chase psychology, physiology, and function and preparedness, not pain and structure. So don't chase finding somebody's perfect pain level, 0 to 10, don't chase finding the exact structure. Chase finding what's in their psychology that's making them potentially likely to experience this pain. What's in their physiology, what's happening, what energy systems are they training or not training? What adaptation do their tissues have that they're really good at versus what adaptation do they not have yet? Function, care more about function than somebody's pain, again, when it's safe and when we're not dealing with red flag symptoms. Make people realize that it's less about their pain, it's so much more about what they can do, because pain is something we are all going to experience. It's not to say that it doesn't matter, it's not to say that it doesn't absolutely impact people's lives, but shifting the goalpost to being pain-free forever, which is completely unrealistic, we all know that, to instead trying to increase function as much as possible while mitigating pain, that's a way more realistic goal. And preparedness, we can prepare people, that's literally our job. Focus on that instead of all the things they're doing wrong, or the things that they think they've overused. Focused on are they prepared or not. So I have a breakout for a little case. I don't know if it's aligned, this is like the last thing. When I have really big groups, I split people up, but it might make more sense to do this just together to kind of talk out some things. It's quick. Something to think about, because I like to now take all that and actually apply it. Probably like 15 minutes anyway. Is that cool with everybody? Or did I go over time? I did go over a little. We started at 2:30.
You're doing a great job.
Are you sure?
Yes.
Like 15 minutes? Can we handle it?
For sure.
Promise? Sorry. Okay. See, I just get so excited. Okay. This is something where it's an example of a case of just really basic stuff, and then thinking of those 4 principles that we just talked about. What kind of questions would you ask to try to learn these things? Because if you just read somebody's intake form and this is all they said, we wouldn't really know where to start. Or we would maybe have an idea in our head of what we think we're supposed to do. But if we try to understand these things about somebody, it's going to give us a hell of a lot more information. So I on purpose did not give a lot of information in the case because I want to go over what questions we would ask to try to get to these principles here. So we have a 42-year-old female with low back pain after a deadlift session 3 weeks ago. She has no red flags or neurological symptoms. We've cleared all that stuff out. She's a physician herself, and she already got an MRI immediately. She stopped lifting and running and has been resting for the past 3 weeks. She's a runner and lifter for over 10 years though, so she definitely has some background in fitness. So pretty limited information here, but we know about her. She herself is a physician, and she got an MRI immediately. She has stopped doing everything, but she does have pretty good training experience. But luckily, she doesn't have any neurological symptoms or red flags that we have to be aware of. So, if we want to take bullet point 1, is this person a catastrophizer or a confronter? First of all, what are some things and patterns you notice that make you think one way or the other? You can just shout stuff out, or raise your hand.
Immediate imaging.
Immediate imaging, yeah, tell me about that. Like why you would make that fit, why that would make you think a certain way.
Well, because they're trying to find something structurally wrong with them to explain the pain they're having.
Yeah.
And I'm not perfect on the numbers, but I've seen some little research suggesting that early imaging increases your chances of getting surgery, whether it helps you or not. So
Yeah.
it sounds like a catastrophizer to me.
For sure, and she's a physician, so she's probably used to thinking in that way, right?
Like, I find like most trainers, we're all like over-diagnosing ourselves because we're around it all the time. So as a physician, she's probably like, oh, I know exactly what's wrong. I'm gonna go get an MRI and then I'll get this fixed.
Exactly, yeah. Oh, like I have pain, so the only thing to do is get imaging. I have to know exactly what it is.
Yeah.
Anything else that makes you think?
Assuming the pain is a problem, she stopped doing everything immediately. Assuming she's injured, assuming she's
Yeah.
broken. Like
Right.
that's the catastrophizer right there.
For sure. She's
Stop.
like,
You said she's been doing it for 10 years.
Yeah.
yeah, like she has a really solid training history, but a little hiccup, and she's like, oh god, this isn't safe anymore. What were you gonna say? Oh, that's exactly what I was. Yeah. I would agree. This is a real case, by the way, too. Total catastrophizer. Absolutely. And she came in with like her folder of imaging immediately. And I'm like, oh boy, here we go. And so definitely not necessarily a confronter, even though again she has good training history. Okay, what things make you think overdoer versus underdoer?
I feel like overdoer just based on what she does for work. That's already overdoer.
Yeah.
And then she runs and lifts, and she's been doing it consistently for 10 plus years. I feel like that's overdoer too.
That's why knowing what somebody does for work is so important. Like beyond just general demographic information that you get on your intake form. If I understand that I'm seeing the physician and they are probably coming from a pretty stressful place. They're not sleeping a ton. They might be more in that type A personality. Again, I don't want you to slap labels on people right away, but these are heuristics that help us too, right? Our brain is finding patterns. Yeah, probably a little bit more on that end of the spectrum. Anything else that makes people think on either way or the other?
I almost want to blend her as an overdoer who's probably underdoing.
Yeah, explain that, yeah.
So like she could be doing everything she's supposed to be doing, but she might not be training progressively smart. She could be running with way too much volume that she can't recover from. That deadlift session could have been a CrossFit session with some crazy physician friends who are marathon athletes who like to destroy themselves for fun.
Right, yeah.
And she could have done that
I
at
just
the end
wanna
of a
feel
90-hour week.
Yeah.
Like,
Spot on.
because she was tired. She felt like she needed to go do something crazy.
Yeah.
I feel like I've met this person.
Has anyone like, I am this person? Yeah, I would agree. Like, this is again where there's a lot of gray area between the two. But yeah, she could be kind of a hybrid of the two, and almost like the more negative aspects of each come together for the perfect storm. And again, this is stuff that I'm thinking, I'm not necessarily telling them. Like, you're a catastrophizer, overdoer, underdoer, and like, I'm not telling people this stuff. It's things that I'm, going through in my brain. Force absorption versus force production issue. So there's not a lot of information here that would give us any insight. What are questions you would ask her to know potentially which of the two categories or type of pain would be related to?
Does it hurt during the flexion or the extension portions of the lift, or what daily activities do you notice it bothering you in, stuff like that?
Yeah. Any other?
I'm gonna lean towards force absorption issue potentially, because if she's a runner and a lifter, she probably is more inclined to produce more force than she's focused on absorbing.
Sure, that could absolutely be a component of it. What are things that you would ask her about her running and her lifting to kind of glean more information on that?
What type of running does she do?
Mm-hmm.
Is she an interval runner? Is she a sprinter? Is she a steady state runner?
For sure.
Is she a marathon person or anything like that? And then just where does she lift on her own with a trainer or do classes? I just keep it that simple and see what she says.
That's perfect. Yeah, simple is good here too for all this stuff. But yeah, absolutely. Like, again, we might get an intake form. We see that somebody runs and lifts, and we're like, cool, they're fit. They know what they're doing. But like, what kind of stuff do you do? What exposures do you have? Do you run fast or do you run slow? Like, paints a completely different picture of somebody, like the type of runner and what they might experience from a force production and absorption standpoint. Same with lifting. Yeah, are you doing CrossFit style where you're doing maybe like a set weight, you're doing a lot of repetitions at a lower weight, trying to go as fast as you can? Are you a power lifter and you're doing 1s and 2s and 3s and never getting exposure to higher rep counts or anything like that? Are you doing only really heavy? Are you doing a mixture of things? Are you sumo or are you conventional? All of those things matter and really can paint a picture for us. What buckets are filled and what needs to be filled? So do we get any information here from things that express like what buckets she's already filling versus needing to be, or what are questions you want to ask her to know more?
Well, I mean, it would lead you to believe that she's probably hitting the physical guidelines, but then you want to ask her on housework, life stress, are you sleeping okay,
Mm-hmm.
have you been gearing up for competition or something
Totally.
like that? Just any changes in your workload or volume recently would make a good difference.
I would honestly go off of physical appearance, and as much as I hate to say it, and immediately ask about nutrition and recovery practices. Because I've seen people like this who don't look like they do this,
Mhm.
and they eat very poorly, they go to way too many happy hours,
Yeah.
and internally they could be falling apart, but they're just doing enough to kind of keep pushing forward.
Spot on. Yeah. People who do these activities, like you could have so many different people almost like a lineup in front of you and not know which of them fits this profile. And again, it's not a point of judgment, it's not a point of casting anything like that. It's more about, our skill set and our training is to find these patterns and to see what matches, what doesn't, what fits, what's an opportunity for us to improve upon. And then this kind of goes back into the conversations and the questions we would ask about the force absorption or force production, right? Like, what type of training do you do? Like, what I always ask people, the things that I get probably 90% of my information from is just say, talk me through an average week of your exercise. And I have them explain what they do. It doesn't have to be in the nitty gritty details, but I want to know roughly how many days per week are you lifting, what type of lifting is it, how many days per week are you running or doing cardio, what type is it? Do you do any other activity besides that? Are they really sedentary but they lift? And that paints a really good picture of that over or under doer as well. I get so much information from just asking that. It goes a lot farther, I think, and it's more important from a capacity and preparedness standpoint than in the PT world, all of these like special tests that we were taught to poke and prod and to like diagnose tissue. If I ask what their program is, first of all, some people might say, what do you mean? So that tells me already they're just going wild and have no sort of program they're following, which is, a lot of us do. But that tells me a lot because they have no way of gauging their effort or their intensity and they don't really know where they're at. Anything else from this that you want to know or ask about? It's not a trick, I'm just curious. I liked everything that you guys said. Yeah.
How would you treat this person?
Oh, who knows? So many options. Yeah, I would probably, as I mentioned, after going through all this stuff, have an idea of kind of where she lies in these things, because that kind of tells me how much I can maybe push that person versus what I would have to pull back on. But I'm gonna for sure find a way for them to hinge that day that doesn't flare them. And it could, again, be something as simple as a bridge isometric. But I'm gonna find a way for them to stress the tissues that matter to us, or target tissues for somebody whose back is flared up from a deadlift. People love when they feel their glutes and hammies instead of their back. So I'm gonna find a way for them to feel that stuff. So that's gonna absolutely be probably what I start with, because I wanna make sure that they're really ready for it. And then I'm gonna sprinkle in stuff that I know is gonna feel good, maybe a squat pattern, maybe something that's a little bit less posterior chain focused. Give them a few reps of those things. And then I'm probably also gonna make sure that at the end I have plenty of time to debrief with them. Probably gonna talk to this person more than do anything with them on the first day. And that's something that, again, in a space like this, we have a lot more of the luxury to do. Not everybody has that luxury to spend extra time talking. But I wanna make sure that by the end of the session, I've given them a positive experience with movement in some way, especially the pattern they're scared of. And then I've had enough time to debrief with them at the end, they can ask questions, and then we can go over anything that they're still unsure of, and then they feel confident in the plan that we've laid out. I might not have the perfect answer of how long this is gonna take. That's always the question people ask. So that's probably a time where I'll talk to them more about how I like to focus on milestones rather than time frames. I want to know the goals you want to get back to and use those as our metrics instead of by 6 weeks you should be here. By 12 weeks you should be here. Because I don't know. We have pretty a good understanding of like tissue healing time frames, just based on like physiology. When are you in the inflammatory phase? When are you in the remodeling phase? Beyond that, it's so variable when things feel better. So I like to spend that time to make sure that they understand that I'm not looking at timelines, I'm looking at the goals that we've set and being able to hit those as how we're showing progress. It also puts us back on the thought of function over pain. Well, I'm not pain-free 6 weeks, like for now, I don't understand. Yeah, but you're back to deadlifting 70% of your 1 rep max and you're not getting flare-ups as frequently as you were. That's a huge win. Time between flare-ups is progress. No flare-ups is not the only form of progress. So that conversation might even be more important to me than doing a ton of movement day one. Does that make sense?
Do you utilize any passive modalities with your people?
I personally don't. We have a few people on the team who like to do dry needling or some like passive stretching and stuff, manual therapy, joint bobs and stuff. Totally fine with what anybody wants to do. I feel the biggest bang for my buck is how I can help people move. So that's what I prioritize on. But you know, there's so many ways to help calm people down. If somebody's extremely flared up, it is not a bad thing to do something a little bit more passive first. It just really depends. But for me, like the results that I see that I feel most confident in are when I'm guiding people through movement. It just depends. Any other questions, comments, or anything about this? Big picture takeaways from today. Training and rehab are one and the same. We're all healthcare providers. Pain is complicated, multifactorial, but actionable. General principles can lead us through any diagnosis. Successful history taking that is human-centered provides a framework and patterns to explore. And sometimes we have to remember we have the coolest job ever. We don't sit at desks all day. We communicate with people from every walk of life and profession imaginable. How many of you guys know such like weird facts about other industries because of what your clients talk about? Like there's like some things that I understand about like tax law that I shouldn't because of what my clients tell me. Like we get exposed to such cool stuff. We also, it sounds weird to say this, but it's true. People like you enough to pay to hang out with you. That's so cool. You are making that much of an impact on somebody's life that they are electing to take an hour, however much time out of their day, to literally come and hang out with you and be around you. That's awesome. There's not many jobs that are like that. There's not many jobs that people actually have the consumer like really wanting to be there. And on top of that, we're impacting their health at a level that goes so far beyond what traditional medicine can do. It's not saying that there's not a time and a place for it, but what we do is pretty damn important and it's so much fun. So I think that's really important to remember too. It's easy to get burnt out, our hours are long. It's easy to feel frustrated because people tend to not see us as humans and not understand if we say that we don't have that time. They get pissed off at us because they don't realize we have other clients. A lot of those things can be frustrating. We work really early, we work really late, it's physical, all of the stuff that can be tough. But at the end of the day, I think we have the coolest job. So that's it. This is the QR code that goes to my little link tree. Anything that we're ever doing at Old Bull or other places is always on there. If you continue to scroll, there's also a place to send me an email if you have questions about today, if you have coaching questions. I do remote coaching as well from a business perspective and like rehab and training perspective. Or if you're ever in Miami and you want to come hang, please come hang in Old Bull. But that link tree is on my Instagram too, but it's where like any happenings that would be going on would be for Old Bull or for myself. How are you doing?
Awesome.
Yes.
What's something you're currently excited about or working on?
Ooh, I didn't expect that kind of question. Something I'm currently excited about. Let's see. Well, I am very excited that our team is growing, and I have a new provider starting in a couple weeks. And so it'll be the first time that with a few people on that team that we're initiating, kind of leveling them up to that mentorship role that we were talking about, like giving them exposure to some leadership stuff and saying, hey, you're in control of mentoring this person. I'm super excited for it because, like, again, our team is just phenomenal, so I'm excited to see them like approach that role, which is gonna be really cool. After just completing this trail race that maimed me, I've already signed up for my next one. So in July, we're doing another trail half marathon at Mount Rainier in Washington. So I'm super excited for that. Just when I like got over the shock of what we had just done to ourselves, I'm like, let's do this again. So those are the two things I'm very excited for. Any other questions? Cool. Thank you guys so much. Sorry this is a little bit longer than anticipated. Did everyone get this who wanted to? Also, I will be sending this slideshow to you guys. So you'll have everything. There's links to the articles and more information in the notes of each of them, so you'll get all of it.
How'd you come up with Old Bull?
My business partner did. Old meaning wise, bull meaning strong. So we take the wise approach to strength and rehab. And then kind of another definition, there's a lot of young bulls in the industry. More kind of the old bulls that don't care about flashy, gimmicky stuff and just do the foundations. What is that, like their strength training is the same 6 movements until you die or something like that. Just foundational rather than like gimmicky stuff.